Welcome to the next lesson. In the previous video, we explore how to analyze the red blood cell indices on the CBC. In this video, we will shift our focus to the white blood cells and platelets, two important components that offer vital clues about the infection, inflammation, as well as the bone marrow function. Let's dive in and discover what these cells can tell us. White blood cells play a central role in the immune response, and their abnormalities often provide important clues in both infectious and non-infectious diseases. We will begin by looking at the total white blood cells, then break it down into the key subtypes, and from there, we'll explore how to interpret common patterns. The first thing we always check is the total white blood cell count, or the WBC. Normally, it should fall between 4 and 10 times 10 to 9 per liter. If it is above 10, we call it leukocytosis. However, if it is below 4, we call it leukopenia. That is your first clue. Is the total white cell count high, low, or normal? But that is only the beginning. After that, we look deeper at the differential count, which tells us the makeup of the white cell population. We focus on 4 main types in this lesson: neutrophils, lymphocytes, monocytes, and eosinophils. Each has a distinct function, and X respond differently depending on the clinical situation. But here's something really important. When we interpret these, we don't rely on the percentage only. What matters most is the absolute count, because the percentages can be misleading, especially if the total white blood cell is very low or very high. So, how do we know when X type is increased or decreased? Let me walk you through the basic threshold, and I will read them exactly how you will see and hear them in real practice. Neutrophilia. When neutrophils above 7.5 times 10 to 9 per liter. However, neutropenia when the neutrophil value is below 1.5 times 10 to the 9 per liter. However, the lymphocytosis above 4 and the lymphopenia is below 1 times 10 to the 9 per liter. And the monocytosis is above 1 and eosinophilia is above 0.5 times 10 to the 9 per liter. You will see these patterns often, and they can guide your clinical thinking in a very meaningful way. So, to summarize, when analyzing the white cell line, it is important to ask, for the total and X type of the white cells, are they increased or decreased? And keep in mind, the cells we are talking about here are all mature cells. We are not yet considering abnormal or immature forms of the white cells. Now let's get started with the neutrophils, the most abundant white cell in circulation. When our neutrophil decrease, we call it neutropenia. There are a few key causes to remember. Drugs are a common reason, especially chemotherapy or certain antibiotics. Severe infections, including bacterial sepsis or viral infections, can paradoxically lead to the neutropenia due to the consumption or suppression. Autoimmune destruction is another possibility, seen in some autoimmune diseases like lupus erythematosus. And don't forget about the bone marrow diseases like acute leukemia or the bone marrow failure. These impair the neutrophil production at the root. And lastly, vitamin B12 or folate deficiency can lead to ineffective hematopoiesis. affecting all cell lines, including the neutrophils. Okay, now, on the other hand, when we see the neutrophilia or an increase when we see the neutrophilia or an increase in the neutrophils, here are major causes. First and foremost, acute bacterial infection. That is your classic trigger. Also, inflammation and physical or emotional stress. This can cause a transient rise of the neutrophils. Corticosteroid use can lead to the demargination of the neutrophils, so you will see elevated count. Again, bone marrow disorders are also important, especially the chronic myelogenous leukemia or other myeloproliferative neoplasms. And finally, some solid tumors can also produce cytokine that lead to the secondary neutrophilia. In short, always think about the context. It is an infection, a drug effect, or something deeper like a bone marrow problem. And remember to pay close attention to the highlighted causes here. They are very common, clinically relevant, and often show up in real-world cases. Now, let's take a look at some other white cell subtypes, starting with the lymphocytes. Lymphocytosis or an increase in the lymphocytes is mostly commonly caused by the viral infection like the EBV or CMV or the viral hepatitis. In some cases, tuberculosis can also trigger a chronic immune response and elevate the lymphocytes. And don't forget about the malignant lymphoid diseases, such as the chronic lymphocytic leukemia, CLL, which can also lead to the lymphocytosis. On the other hand, lymphopenia, or decrease in the lymphocytes, does occur in some conditions like HIV or severe infection, but these are less commonly seen in the routine blood tests. I won't go into detail here. Next, let's move to the monocytes. An increase in the monocytes or monocytosis is often associated with the chronic inflammation, especially tuberculosis. It also commonly seen in during recovery after an acute infection, as the immune system clears debris and repair the tissues. Finally, eosinophils. If our eosinophils are elevated, that usually point us in two main directions. First, parasitic infections, especially tissue-invasive parasites. Second, allergic reaction, such as asthma or fever or drug allergies. So, in summary, lymphocytes increase in viral infections and lymphoid malignancies. Monocytes increase in the chronic inflammation and tuberculosis. Eosinophils increase in the parasites and the allergy. Now, apply this knowledge to some clinical cases. Let's work through a clinical case together. We have a 65-year-old man, a chronic smoker, presenting with a persistent cough, fever, fatigue, and poor of appetite. On physical exam, his tachypnea, using accessory muscles to breathe, and has positive pulmonary brels. Now, let's check his CBC result. His white blood cell count is 15.5. That's elevated. His neutrophils make up 85%, and the absolute neutrophil count is 13.2, also clearly increased. Lymphocytes, monocytes, eosinophils, and basophils are within or below normal ranges. So what is the pattern? Leukocytosis, blood, neutrophilia. Now let's ask, which cause should be more strongly considered? And now we have four answer choices. Let's think about the answer. And the correct answer is A. Bacterial infection. Here's why. Neutrophilia is most commonly seen in acute bacterial infections. His clinical signs, fever, cough, lung rales, all fit that picture. So now let's move on to another case. Alright, here's another case to consider. We have a 38-year-old male work as a farmer who has never received deworming treatment. He represents with a 1-week history of cough and shortness of breath. On exam, his temperature is 38.2 degrees Celsius and he tachypnea and has positive pulmonary rales also. Now let's look at his CBC. The white blood cell count is 13.8, so that is elevated. Neutrophil is 50%, still within the range. And lymphocyte and monocyte is normal. However, here is the key. Eosinophil is 16%. That's a makeup 2.2 times 10 to 9 per liter. That is a clear eosinophilia. So what is the interpretation? Leukocytosis and marked eosinophilia. Let's now ask, which cause should be mostly considered in this patient? And we also have 4 answer choices. Yeah, and the answer is C, Loeffler syndrome. Why? This is the farmer likely exposed to soil and animal feces and hasn't been dewormed, so a parasitic infection is a strong possibility. Loeffler syndrome is a transient pulmonary infiltrate of eosinophilia, most commonly caused by the larval migration of helminth through the lungs. His clinical symptoms, respiratory, systemic, and eosinophilia, all point toward it. Let's move on to the next case. Now we have a 47-year-old man, previously healthy, now presenting with a persistent cough and a significant weight loss of 8 kilograms over the past 3 months. His temperature is 37.8 degrees Celsius. He also tachypnea and positive pulmonary rales on auscultation. Now let's look at his CBC. The white blood count is 10.6, borderline elevated. Neutrophils within the normal limit. Lymphocytes is 40% with the 4.3 times to 10 to the 9 per liter. That's on the high end. And monocyte is 1.3 and make up the 12% is also elevated. So this is a case of myelocitosis with the lymphocytosis as well as the monocytosis. Now let's think about what cause must be considered. Okay, now let's think about this. The chronic cough, low-grade fever, weight loss, and increased lymphocytes and monocytes all point toward a chronic granulomatosis infection, and tuberculosis is the classic one. So our correct answer is D. Lymphocytosis is common in tuberculosis, especially in subacute or chronic presentations. Monocytosis may also reflect the chronic inflammation or even a macrophage activation. So, in the right clinical context, especially in the respiratory signs and constitutional symptoms, tuberculosis should always be high on your differential. Let's keep going. Let's take a closer look at this case. We have a 70-year-old male with a history of gout admitted to a hospital for swelling and pain in the first metatarsophalangeal joint. He's already receiving pain relief treatment, and now on day 4 of admission, a CBC is performed. And the results show the WBC is 12.5, so it is elevated. And the neutrophil is 80%, with the absolute count is 10, significantly increased. So now comes the key questions. What is the analgesic currently being used in this patient? Take a few seconds to think about this. And the most likely answer is corticosteroids. So the answer is C. Why? Because the corticosteroids are commonly used for pain relief in gout, especially when NSAIDs are contraindicated or not tolerated. And more importantly, they can cause the neutrophilia not due to the infection, but through the damaging and prolonged neutrophil lifespan in our circulation. So here is the clinical pill. Not all neutrophilia means infection. In some cases, it could be a medication effects like corticoid. That is why we always correlate the lab result with the clinical context and the treatment history before rushing to conclusion like sepsis or starting antibiotics unnecessarily. Now, let's take a moment to talk about the leukocyte differential. Specifically, how we interpret a pattern of predominance in white blood cells. When neutrophils are predominant, it often points us toward acute bacterial infections or conditions like chronic myelogenous leukemia if our white blood cell count is increased. On the other hand, if we see the predominance of lymphocytes or monocytes, we should consider the viral infection, the chronic lymphocytic leukemia, or even the bone marrow failure. But remember, not all reverse neutrophil to lymphocyte ratio mean the same thing. Let's highlight 2 important points. First, in viral infection or CLL, lymphocytes are truly increased. That's why the ratio flips. But in the bone marrow failure, it is a different story. Here, neutrophils are reduced, which makes lymphocytes appear relatively predominant. So the ratio reverses, not because the lymphocytes rise, but because of neutrophil fall. And one more important but finally, in acute leukemia, you may also see a reverse ratio, but the reason is very different. That's something we'll explore in the next slide. Here we have an important slide to help us recognize and think critically about abnormal cells, particularly blast cells. Take a look at the images. We are comparing the normal lymphocytes and monocytes, as well as the lymphoblasts and the myeloblasts. Blasts are immature precursor cells, and one of their key morphological features is the lack of the cytoplasmic granules. Because of that, in automated hematology analyzers, the blasts often can't be classified as a distinct group. Instead, the machine may misclassify them, smaller blasts as the lymphocyte and larger blasts as the monocytes. That is why we sometimes see a false increase in the lymphocyte and monocyte count, when, in fact, the increase is due to the circulating blast. And remember, blasts should not normally appear in our peripheral blood. So, whenever we see an unexpected or unexplained increase in the lymphocyte or monocyte, we need to think of blast as a possibility. At that point, a peripheral blood smear becomes essential. It allows us to examine the actual cell types and clarify whether those lymphocyte or monocyte value in the CBC test reflect the normal mature cells or something more serious like leukemia blast. Let's briefly compare acute leukemia and chronic myelogenous leukemia (CML), two important causes of white cell abnormality in the bone marrow malignancies. In acute leukemia, the key issue is an increase in blood cells. These are mature cells grounded in the bone marrow, leading to the moderate to severe anemia. Often low platelet count, white blood count may be increased or even normal or low. And you will often see a reverse leukocyte differential, meaning the lymphocyte or monocyte value appear predominant. But it is actually due to the blast appear in our peripheral blood, not the leukocyte or the monocyte truly. In contrast, the CML is the chronic myeloproliferative disorder, with an increase in the granulocytes at all stages, from the myelocytes to mature neutrophils. And their anemia tend to be mild to moderate. Platelets are usually increased. White blood count is typically high, with a neutrophil the predominant picture on the differential count. So, by analyzing the CBC patterns across all three lines, red cells, white cells, and platelet, we can gather important clues to differentiate between these two disorders. Let's pause for a moment and think about this case. We have a 2-month-old infant, brought in a routine health checkup. Everything looked fine clinically. She is healthy and growing well. But then we look at the CBC. The WBC is 11.5 and the lymphocytes are predominant with the 56%, while our neutrophils are only 38%. Now, here is the questions. Could this still be a healthy child? Or should we worry about something more serious like leukemia? Before jumping to the conclusions, let's take a step back and review how white blood cell count normally change in children. To answer that question, whether this baby is healthy or not, we need to understand how white blood cell changes with age. Let's look at the two important trends. On the left, you can see the normal white blood cell count is highest at birth, then gradually decreases with age. On the right, we have the leukocyte differential shift. At birth, neutrophils predominant. Around day 5, lymphocytes start to increase, and by the 5 months, lymphocytes are clearly predominant. Then, from age 5 to adolescence, neutrophils take the lead again. A simple way to remember this is the 5, 5, and 5. With day 5 is the lymphocyte catch-up, month 5 with the lymphocyte peak, and year 5 with the neutrophil take back to the lead. So back to our infant case. A 2-month-old should naturally have the lymphocyte predominance, not the neutrophils, and their white blood cell count can still be slightly above the adult range. Now, that will reveal how the white cell composition shifts with age. Let's revisit our 2-month-old infant. The white blood count is 11.5, which is perfectly normal for this age group. Neutrophils are 38% and lymphocytes are 56%. Again, this matches the expected pattern at the 2 months where the lymphocyte predominance is normal. So, when we interpret this result, there is no abnormality in the white blood cell. This CBC is entirely consistent with a healthy child, not infection, not leukemia, not marrow failure. And that is a great reminder. Always interpret CBC results in the context of the patient age, especially in the pediatrics. So now tell me, would you be worried if this was your patient? Now, let's take a look at this case. We have an 18-year-old female student, previously healthy, coming in of a general health checkup before starting college. Let's analyze her CBC. The hemoglobin is 11.3 gram per deciliter, with the MCV is 95 femtoliter, and the MCX is also in normal range. So this is K of the normocytic normochromic anemia. Her white blood count is within the normal range, but notice something interesting. Neutrophils are low, only 28%, while lymphocytes are elevated, 66%. So there is a reverse neutrophil to lymphocyte ratio. Now, what might this mean? This pattern could be due to first, a viral infection, which is quite common in young, otherwise healthy individuals. But we also need to consider early stage acute leukemia, especially when the lymphocyte predominance appear without clear symptoms. So, at this point, we don't rush to a diagnosis. The best course of action: repeat the CBC test after 2 weeks. If it is a transient viral illness, the CBC will return to normal. But if there is an underlying hematologic condition, the abnormality will persist or even worsen, and we will know to investigate further. Now let's check the follow-up result. This is the same 11-year-old female student from earlier case. Her CBC was abnormal during a routine checkup, so we repeated the test after 2 weeks. Let's see what changed. Hemoglobin remained low, 10.8 gram per deciliter, consistent with the normocytic normochromic anemia. White blood cell count is still normal at 7 times to 10 to 9 for every liter. But the neutrophil to lymphocyte ratio is still reversed, with the neutrophils are 29%, while the lymphocytes are 64%, not much different from the last test. That brings us to the key questions. If this were just a viral infection, you would expect the lymphocyte count to return to normal after 2 weeks. But it hasn't. Now we must be more concerned. Persistent reversal of neutrophil to lymphocyte ratio in the absence of the clear symptoms raises the possibility of acute leukemia, particularly if the lymphoblast or the monoblast are present, but being misclassified as mature lymphocyte or monocyte by the automatic counter. So what is the next step? We cannot rely on the CBC alone anymore. We now need to order a peripheral blood smear. And then we order a peripheral blood smear, and unfortunately, the results show something more concerning. Blasts were detected in the peripheral blood smear, and not just a few. The number were prominent enough to raise immediate suspicion. And then a bone marrow examination was then performed, and the diagnosis was confirmed: acute lymphoblastic leukemia, ALL. Now that might sound like very bad news, and of course, it is a serious diagnosis. But here's the part I want you to remember. It was caught early, purely because of routine checkups and careful follow-up on the subtle abnormalities. And even better, this patient had a subtype of ALL that responded well to treatment, a favorable risk variant. After a few cycles of chemotherapy, she achieved full remission, and to this day, it's been about 7 or 8 years, she is alive and well. This is a powerful reminder Early detection matters, and sometimes just being cautious with a CBC can change the courses of someone's life. And here is a case I encountered back in 2023. A 21-year-old male student from the CTUMB, our university. He was completely healthy, just came in for a routine checkups, and had a CBC performed. Now, when we look at the result, the one thing that stands out is monocyte is 11%. That is clearly elevated. So the first question we should ask is, could this be blast being misclassified as monocyte? That's something we always need to consider when we see the monocytosis, especially if it is significant and our analyzer cannot be classified the monocyte or lymphocyte with the blast. But there is an important clue here. The neutrophil to lymphocyte ratio is still normal in this case. If this were the acute leukemia, we might expect a reverse neutrophil to leukocyte, to lymphocyte ratio, or more widespread abnormalities. So the possibility of false monocytosis due to blood is less likely, though not ruled out entirely. What do we do next? We go back to the basic, take a detailed history. And here is where everything makes sense. He had a recent high fever about 2 weeks before the test, likely a viral illness. So this is most consistent with the post-infectious monocytosis, a very common finding during recovery. Not every abnormal result signals danger. Sometimes it's just the immune system doing its job, like in this case. And when interpreting the platelet count, there are two key abnormalities to look out for. Thrombocytopenia, when the platelet count is below 150. Thrombocytosis, when the platelet count is above 450. Let's go over some important causes, especially the ones you should remember for the clinical decision making. When platelet count is low, one major group of causes involves bone marrow dysfunction, such as the acute leukemia, where normal platelet production is suppressed. Bone marrow failure from conditions like aplastic anemia. Another important group is immune-mediated causes, like immune thrombocytopenia or viral infection. Think about Jan virus. On the flip side, when platelet count is elevated, one serious cause to consider is bone marrow proliferative disorder, especially the chronic myelogenous leukemia, CML. So, whenever you see the platelets that are too high or too low, always ask yourself, is the bone marrow involved? Is this reactive or primary? And remember, there are many other causes that can alter the platelet counts. I've included them here so you can refer to them during the clinical practice, especially when analyzing a specific case. And now, let's take a closer look at this case. We have a 38-year-old woman who was previously healthy, and she now presents with a petechia and menophagia that has lasted for 10 days, with a significant daily blood loss of 8 to 10 bags. She also complains of fatigue and dizziness. This clinical picture immediately raises concern for anemia and possibly thrombocytopenia, given the bleeding symptoms and petechia. Now, let's interpret the CBC result. The hemoglobin level is 8 grams per deciliter, confirmed moderate anemia. Platelet count is 10, and this is the marked thrombocytopenia. While the white count and the neutrophil as well as the lymphocyte are in the normal limits. So we are looking at this case of isolated anemia and thrombocytopenia without leukopenia or leukocytosis. What could be the cause? In this case, the history gives us a big clue. The patient had a prolonged menorrhagia, and the platelets are extremely low, which could lead to ongoing bleeding and worsening anemia. So the anemia is likely secondary to the blood loss caused by the severe thrombocytopenia. We should check the reticulocyte to accept the bone marrow's response, and here is the key finding. The reticulocyte count is 15%, which is clearly elevated. This tells us that the bone marrow is functioning well. It is trying to compensate for the blood loss by producing new red cells. So, what is the conclusion? It is a case of secondary anemia due to the thrombocytopenia-induced bleeding, and the bone marrow is responding appropriately. At this point, our focus should shift to investigating the cause of the thrombocytopenia and managing the bleeding risk. Now let's take a look at this next patient. We have a 48-year-old male, previously healthy, who has been experiencing progressively worsening fatigue and pallor over the past month. On exam, his skin and mucous membrane are pale, but notably, there is no hepatosmegaly and as well as the splenomegaly. So we are dealing with the case of chronic fatigue and anemia-like symptoms. Now let's take a look at the CBC result. What did we find? Hemoglobin is 8.2 gram per deciliter, confirmed anemia with the normal cytic and a normal chromic. And his white blood count is 3. It's confirmed the leukopenia. And his platelet is 30. It's also confirmed thrombocytopenia. So in this case, that is all 3 cell lines, red, white, and platelets reduced. And there is also a reversal of the neutrophil to lymphocyte ratio. The neutrophil only 32%, while the lymphocytes are 67%. This isn't due to an increase in lymphocytes, but it's more about the low neutrophils. What does this pattern suggest? This is pancytopenia, and when we see the pancytopenia with a normal MCV and MCH, one of the first things we need to consider is the bone marrow failure. The marrow may be failing to produce cells, whether due to the aplastic anemia, myelodysplasia, or some other diseases. What is the next step? There is only one reasonable answer here. The bone marrow examination, especially the bone marrow biopsy. We need to confirm the underlying pathology. The bone marrow aspiration and especially the biopsy will give us the clearest answer. Summary takeaway for this case. This is the classic presentation of the bone marrow failure, anemia, neutropenia, and thrombocytopenia, all pointing toward an issue at the source of the hematopoiesis. We have just covered the core foundational knowledge for analyzing white blood cells and platelets on the complete blood count. In this lesson, you were introduced to the key principles, how to identify abnormalities, and how to apply them in the basic clinical reasoning using the CBC test. I hope these concepts will help you feel more confident when interpreting the blood count in the practice. In our upcoming in-person lesson, you will have the chance to walk through the real clinical scenarios and apply what you have learned to interpret the CBC result in the context. Wishing you all good health and success in your studies. See you soon in class. Thank you for watching our video. Goodbye.